Yeah. First of all, I would like to thank Dr. Abhay for giving us this opportunity and accept our invitation to be a guest of honor for our conference. Actually, his presence in the conference is an add value for us, and we are learning, and everyone, I think, learn from Dr. Abhay. Many years we are listening for him and his books and his lectures everywhere. So everyone, everywhere in the world knowing Dr. Abhay. He is a director of LED cataract and IOL research, and Deep Eye Hospital in India. And he is going to talk about giving a talk about tackling the malposition IOL new kid on the block. So without any further ado, please, Dr. Abhay, share with us your experience. We are waiting for that moment to learn from you as usual. Please.
So sorry for the delay. And I really am honored to be here in the 7th meeting. And I can't thank enough my friend, Dr. Ambry. This is my financial interest. And this is a topic which is of getting relevance as we progress in our career. And late decentration and dislocation of the IOL really is increasing. And in recent time, it is like an epidemic that patients we have done uneventfully come back after either 5-6 years or 10, 15 years, 20 years, and they have a malpositioned IOLs. And if you look into the literature, the common reasons cited and observed are pseudo-exfoliation, a history of posterior segment surgery, homocystinuria, retinitis pigmentosa, high myopia, and increased capsular phimosis and fibrosis. And in 2009, a big series by Dr. Alan Crandall group reported pseudo-exfoliation and vitreoretinal surgery as the common reason for that late in the bag implantation. And other studies showed high myopia as the main risk factor for late in the bag IOL decentration. We did the analysis of our 28 cases in last 6 months, and we found that the spontaneous, without any reason, was quite common, followed by pseudo-exfoliation and history of vitreoretinal surgery. So we need to look into that, but homocystinuria is something it is underdiagnosed, I would say. And we found 2 peaks, one at around 6 to 10 years and another around 20 years in these 28 cases that we analyzed. And we found that there are 2 ways the late decentration occurs, where the IOL is placed in the bag, has remained in the bag without any problem for a few years. And then suddenly, one of the mechanisms is the spontaneous rupture of the posterior capsule, but the zonules are intact, and the capsular axis bag is still in its position. And through the posterior capsule defect, the IOL subluxate. This is not a common thing, but it does occur. I would say 2 out of 10 would be of this nature. And this is one example with intact zonules, intact capsular axis margin, fibers, everything is intact. And eventually the IOL goes, dislocates through that rupture with still intact anticapsule and zonules. But this is, the second one is more common. Dislocation of the bag IOL complex or IOL itself, and that's because of the zonulopathy. And any IOL, it can occur. No IOL is immune to this. So it could be hydrophilic, hydrophobic, 1-piece, 3-piece, whatever, PMMA. And that's the common way the late decentration occurs. And the management, obviously the surgery, but vitrectomy is the key. That will decide the fate of the eye, and how a surgeon manages is very critical. Second then step would be where you're going to fixate the IOL. And I think working with retinal colleague now in the modern time is mandatory. It's so important that either you have, if you are lucky to have a retinal colleague in your institute or in your practice, you must have him scrub and do his part, and which is vitrectomy and bringing the IOL in front so that then you can take over. Or you get the referred to retinal colleague, and then it will complicate because you will have a two-stage, first vitrectomy and then the IOLs. But working with retinal colleague is mandatory, co-management. And if the bag IOL complex is intact, we can refixate. But typically, that's rare. Typically, we need to explant the IOL, exchange it, and then along with the pars plana IOL, and then fixate the IOL. Now, this is logical, but it's possible only when the actual bag and the IOL is intact with posterior capsule intact as well. So this is an example where we put a double NI-radial ring because he had a traumatic mydriasis and a cataract. And we did it 5 years prior to his coming here. And when he came 5 years later, this is how it looked. That whole thing kind of gave way. And we decided to refixate. So this is, you can see the NI-radial ring. There are two rings sitting inside the bag. And entercapsule is stuck to the ring and the IOL. So we need to create a cleavage and a space. And I'm doing it with 27, 26, 28 gauge needle, which is very sharp and it's very easy to handle. And you need to approach that from different side ports. So you may have to have 2 or 3 side ports to free that ring complex from the fibrotic anterior capsule. And once you do that, then iCamera segmental ring is something I prefer and like it here in such cases. So these are threaded, and my suture material of preference is Gore-Tex because it's not degradable, but 5O Prolene is also another alternative. So I'm using the Gore-Tex and created a flap, scleral flap, and using the 25 gauge sclerotomy with a needle, I'm using that threading and rail tracking on that side. So I'm using Gore-Tex, and both these are in front of that. The whole suture material is between the capsule and the back of the iris. And the same thing is done on both the sides. So two ends of the same meridian are fixated with the 2 segmental rings. And this is how it looked a week later and down the line over a year or so. So that's one way of refixating. This is not a common way. I wish I could do this, but unfortunately, most of the time I end up exchanging the IOL. And typically, there are 2 groups of techniques. One, you can use iris clolens or a retro iris, or through the sclera using the suture material. So these all either use the glow part of the IOL or some suture material. And we learned over the time that non-degradable, like Gore-Tex, is something which is preferred, or 5O Prolene through the sclera, through the sclera, or retroiris. But transcleral suture is something we had a lot of experience, and we always used Gore-Tex for a few years. And first of all is to create a flap. I'm using Dr. Agarwal's marking system, and I create a flap so that I'll eventually bury those transcleral fixated material underneath the sclera. This is the Gore-Tex suture, which is actually used by the cardiothoracic surgeon suturing the pericardium, and sometimes the suture periosteum also. So it's not degradable, but it's very long thread. It's very clumsy to use it. So I cut the needle, and then through the 25 gauge forceps, I take it out, that thing, as I said, behind the iris through the sclerotomy, having done a vitrectomy. So the leading haptic and then the trailing haptics are kind of threaded. The suture material is grabbed from the 25 gauge needle and brought both ends under the flap, and then the IOL itself is implanted, you can do one at a time. I preferred at that time to thread both the haptics hole, and this is a PMML lens. It needs a larger incision. So this is a negative, but the good part is that it is very predictable, and there is a very minimal chance of IOL tilt or misalignment in this transcleral suture fixation. This one more example of a two Qoic suture being brought out one by one at a time, and then the trailing haptic also is threaded. And at this time, the iris spatula supports that pull so that iris is not pulled into the incision. So it is less traumatic, but whatever you do, it is indeed a little fiddly. You can see so many sutures coming in and out, and you need to be careful not taking the wrong one. So the whole IOL is still sitting out. Having done that 4 things out, you can shove the IOL in, and then this is how it looks. It's very predictable, but it takes time. It looks a little messy and fiddly, but it works every time. So I would recommend for those who are not used to the other techniques, this is it's not difficult, easy to learn. And we published in American Journal our results in 2020 of 100 eyes, where scleral fixation of IOLs with this Qoic suture was very safe and well tolerated, had a well-centered IOL with very little suture-related complications in that follow-up that we have. But I prefer, for a few years now, intrascleral IOL fixation. And intrascleral fixation, the more popular technique until now was the glued IOL technique, which was originally conceptualized by Geber Shariath, which Dr. Agarwal, my friend, made it very simple and easy to use. This is an example of a child who was done a phakic somewhere else. No, not a phakic, pseudophakic, but had a then secondary IOL, which got dislocated, and that's where it came for us. First thing is to remove this fibrotic structure and do a vitrectomy. So pars plana vitrectomy is something we need to consider here. And if you are not used to it as a cataract surgeon, Rachel colleague will help you to do that. And because it was a 3-piece IOL, I prefer to use the same IOL for the glued IOL technique. But quite often I remove that IOL because many times these haptics they lose their memory, they are distorted. So if slightest doubt, remove this lens and use a new 3-piece IOL. But here I thought this is fine, and it worked quite well. So position that IOL and then introduce to the sclerotomy. At this time, I was using 23 gauge, which was the largest sclerotomy at that time, and grab the very tip of the haptic, not the shaft of the haptic, and bring it out and tuck it into the intrascleral tunnel, which is done little bit away. I enter sclerotomy 2 millimeter away from it, not very close, because 2 millimeter is a distance where the pars plicata ends and pars plana begins. So I would recommend 2 millimeter away from the limbus, not very short, not very long. And then once again, other haptic is tucked in. But remember, I recommend performing pars plana vitrectomy through separate pars plana port, not through the same port through which you are trying to bring the haptics, because pars plana entry is 3.5 millimeter away and not 2 millimeter away. So separate pars plana entry and 2 millimeter away sclerotomy under the flap, you can do that. But my preferred technique for last 3 years is Yamani technique, which is a great appeal because you don't need to perform the flaps or any bleeding and all the other things. This is an example. I will show you 2 examples. A retinitis pigmentosa case, which is a known case of risk factor for late decentration. Few years ago, we did it, and this is what he had. My retinal colleagues then, I just marked the eye for the Yamani techniques later on, and then prepare a groove, not entering the eye, scleral, so that astigmatism is less. And then my colleague makes 3 or 4 pores, and then does the vitrectomy and make sure that he does a good vitrectomy. He will check the periphery of the retina as well. And then we need to remove the IOL, which is not a big deal. You can fold it, but I prefer a larger incision rather than folding. It's less traumatic. But notice that this is this point and this point are in the same meridian, 2 millimeter away from that in the same meridian, both sides, and then further 2 millimeter circumferential, where you introduce 30 gauge needle, which is a special needle, thin walled needle, not the ordinary 30 gauge. 30 gauge thin walled needle will allow us to take the haptic inside very well. So one dot to other dot, and then turn 90 degree and bring it behind the iris, and then using 25 gauge Greiff-Shaver forceps or whatever forceps you have, very delicate 25, you thread this leading haptic into that 30 gauge needle and bring it out. Original Yamani technique, and probably it is better, doesn't take it out at this stage. He will keep it inside with a needle in, but I use the cautery. You can use any device you like, but you create a little mushroom or a little flange so that it will not get inside. And you can titrate your flange if you're not happy doing more. Now, same thing, the trailing haptic is outside. You introduce from one dot with this 2 millimeter circumferential, come to the 2 millimeter, and then turn it 90 degree and bring it to the behind the iris and bring it out at the incision. You may bring it out of the incision or keep it at the incision, doesn't matter, whatever is convenient. And then you thread it as you did, and then bring it out again in the same manner. And you can then use whatever cautery you have. Many surgeons use the disposable battery-operated cautery. I have a problem with the sterility and holding it, so I use the simple heat cautery, but whatever, it's not a big issue. But having made the mushroom there, you can then tuck that in. It doesn't actually go inside the sclera every time, but it will go away from the conjunctival opening, and it will sit on the superficial scleral fibers. It may not actually go inside every time. If you prepare a big flange, it will never go inside. So be careful about the size, but this is how it will look at the end. The IOL remains very stable. My colleague then will check the periphery and make sure that the vitrectomy part is okay. And this is how it looked a few days later, that eye. It's very predictably well centered. You need to monitor the peripheral retina, central retina, and so on. This is one more example of that technique where you need to mark, and this is the key part of it. The crux of the technique depends on the accurate marking. And I've developed a marker, which is not in this film, but you make sure that your marking is perfect, the direction, because if it is not, the IOL will get tilted. And I'll show you the tilted example a little later. But make sure that before you begin, dry the eyes with the sponges. Make sure you tilt, it doesn't fudge the fine point marker pen, and 2 millimeter from the limbus and 2 millimeter circumferential from that in the same meridian. Prepare the groove, and then let the vitrectomy be performed by the retinal colleague. And this is the explantation, which I think we can, with the time, do that. Close the eye after removing the implant, the original IOL, so that IOL is, the chamber is stable. And then this case had a sommering ring, which my colleague removes and takes time to do that, because many of these has a lot of sommering ring. It will drop later on. So make sure that you really clean the peripheral well, and you need a combination of vitrectomy and forceps and whatever you have. So this is the eye, which is now.
Dr. Abhay, if we can manage to conclude.
Yeah, okay. So, right, okay, I agree. I'm sorry. So the way to do is to thread this again, and produce a cautery, and then you will have a good outcome later on. Same thing, you can do pupilloplasty and so on in that case. So complications of this technique are related to hypotony, macular edema, corneal decompensation, granuloma, pupil capture if there is a tilt, and this is not uncommon in Yamani in a learning time. So that marking becomes very important, and the thing with the Gore-Tex, if it is exposed out of the flap, it will produce a granuloma. So be careful that you do that. So finally, I think we need to understand the pathogenesis of dislocation, late dislocation. Surgical management has several options, and depending upon your experience, you can do that. Co-management is crucial, and Yamani has an appeal, although I must say glued IOL and iris claw and all other techniques works well if you keep doing it. So thank you for your patience, and sorry for the delay and the time I took. Thank you so much, Dr. Emery and colleagues. Thank you.
Thank you very much, Dr. Pai, for this excellent presentation. You take us in a journey in all different types of way of management of dislocated, subluxated lens, and removal the old lens and do another one. As we are running behind the time, but I have only one question. You are having experience. Is there one things that you prefer? I mean, and you feel it is more better to use? I know there is, you move or you talk about that one. You start on scleral fixation with Gore-Tex, then you are now using Yamani. Which one is more, I mean, you think is more better in your hands now?
I think first is, before I say that, a retinal surgeon is a must, co-management. So just remember, vitrectomy, pars plana vitrectomy, good, because otherwise you will end up in many complications. Now, if you're not done it, I would suggest scleral fixation using suture. I started with 9-O-proline, but 5-O-proline may be more easily available than Gore-Tex. So, but suture through the sclera using PMM length to give hands-on for 5-10 cases, you understand how to maintain the chamber, avoid hypotony, iris prolapses, and so on. Once you get a confidence in suture related, I would think straight away you can go to Yamani. You don't need to pass through the Gabor or glue technique if you want to, because it's easier in many ways. The key is the marking. So make sure their marking is on the same meridian and the tilt will be less. So this is my approach. Start with the sutured IOL through the sclera, and then, but if you use iris claw, for example, for other things, that's another option. I have not used that, but so for me, that was my journey.
Thank you very much, Dr. Abai, for this, for give us this opportunity to welcome you and to give us and to share with us your experience. We learn from you a lot as usual. Thanks a lot. Thank you. My regards, and we hope to see you inshallah in future. Yeah. Thanks a lot. Thanks inshallah, a lot.
I'll be there in person, I hope.
Inshallah. Inshallah.
And thank you once again. Thank you. Bye. Goodbye.
Okay. Thanks a lot and goodbye. Bye bye. See you.